Hi guys, so we did Crohn's disease was our case study. It's Shania, Katie, and Susan. And our patient was named Mike Page. He's 35. He's a male Caucasian, and he came in complaining of unbearable abdominal pain, constant diarrhea, and a fever. He's married with a 5-year-old son, is a high school teacher working an average day from 8 a.m. to 4:30 p.m. His son is totally fine with no problems, and same with his wife. He was diagnosed with inflammatory bowel disease 3 years ago, but it kept progressing, and he finally got diagnosed with Crohn's. The pain has become unbearable since school started, and he's been to the doctor before. They switched him medications, and now he's taking 6 mercaptopirin, and he's no history of any alcohol use, tobacco use. He hasn't had any major surgeries, and his family history is pretty clean, so no Crohn's disease before.
Okay, so what is Crohn's disease? Crohn's is an inflammatory bowel disease that causes chronic inflammation of the GI tract. So it can be caused with like any part, so from the mouth all the way to the anus. So it's often described as skipping because it does happen typically in multiple parts of the GI tract. The most common affected area is the ileum and the colon. So this is just showing where everything is, specifically the ileum and the colon. Okay. So prevalence, it's equal between genders for the most part. It's typically higher among Caucasians. So with our patient, he is Caucasian. So that's one of his few factors that come into play that are typical within research. Ethnic groups with Ashkenazi Jewish ancestry as well. And then the highest prevalence is found in countries of Northern Hemisphere, which is shown here on the map. Risk factors. Environmental is smoking, diet, infectious agents, psychological changes causing inflammatory responses within the GI tract. Our patient, he's never smoked. We haven't talked a lot about his diet yet, but I was surprised to see that he didn't have any of those. Genetically, when you're related to someone with Crohn's, it increases your risk by 10 to 20%. Our patient also doesn't have any family members that have it, so that was a surprise as well. And then immune system issues, inappropriate immune system responses cause inflammation within the GI tract. So obviously has that. Anybody who has Crohn's is going to have that. Diagnosis. Age of diagnosis is typically when you're younger, so 15 to 30 years of age, and our patient falls within that age range. In order to be diagnosed, doctors are going to try a lot of different tests. They're going to rule out every other possibility before they tell you that you have Crohn's. It's typically found from blood test, and then they'll do a stool test and multiple procedures. Colonoscopy, computerized tomography, magnetic resonance imaging, capsule endoscopy, and balloon-assisted enteroscopy.
So the pathophysiology of Crohn's, this is kind of just a picture of what the patient goes through when they have Crohn's. It's just a lot of pain in the large intestine and the stomach areas. It's been described by multiple things like a fire, like it's prickly, or it's like somebody's just got a hold on it and is like clamping down. Crohn's disease is when a person experiences relapse of inflammatory bowel disease, which is what happened with our patient. He thought that he had it until it just kept progressing into Crohn's. Crohn's disease starts with the inflammation of the glands that line the intestine, and these inflamed cysts turn into small ulcers, and this creates damage of the lining all the way down. And before this process develops far enough to be categorized as Crohn's, it may give a lot of milder symptoms, which is what Mr. Page experienced in the beginning. He just had like some stomach pain, but then it increased to like diarrhea and unbearable pain. And the walls of the bowel thicken, and the mesentery combined with the inflammation may lead to hypertrophy of the mucosae fibrosis, which is like part of the bowel, and if it obstructs, then it could be also very, very painful. It's definitely an explanation for what Mr. Page has been feeling, and it could help, or it could like give indication of why the medications weren't working in the first place. There's no clear cure for Crohn's right now, but managements includes things like steroids, which is what he's on, and in serious cases, surgery, which Mr. Page hasn't had to do yet. Possible contributions to the disease include just genetics, which isn't in Mr. Page's family, but that doesn't mean he couldn't get it. Environmental risks, a lot like smoking, and there's an increased risk of cancer in the small bowel that are inflamed with patients with colonic involvement. And then chronic malabsorption may cause nutritional deficiencies, and particularly vitamin D and B12. So he definitely needs to be prescribed with vitamins and minerals to supplement that. Right now, he is taking 6 sorry guys, I can't pronounce it, mersapoterin, which a lot of his side effects are headaches, nausea, vomiting, diarrhea, tiredness, mouth sores, rash, fever, joint pain, low blood counts and anemia, and liver inflammation. So we need to keep a look on his iron and make sure he's not falling too low in that. Indications include autoimmune diseases and lymphoma. And then there's no real interactions with nutrients, only he might need some supplements, like I said earlier, with the vitamins and minerals. And then he plans to go on Humira. He hasn't started yet, but the side effects of that include fever, sweats, chills, muscle aches, cough, shortness of breath, weight loss, which is something he's been experiencing already, so that's something we'd have to watch out for. Painful urination, stomach pain, and more tiredness. These are all the indications that could happen just because of going on Humira, and a lot of things that Humira is used for. In interactions, metabolic and nutritional disorders, so dehydration, which means he needs to keep his water levels pretty high. He might have some more trouble healing, ketosis, paraproteinemia, peripheral edema, and then there's no real drug and nutrient interactions here either.
Okay, so we looked at MP's lab results and we categorized them out here on our slide. So one of the first ones was his glucose levels were higher than what they were supposed to be. And he came in on 12/15 at 74, and the normal levels are 70 to 99, which was fine. However, on 12/19 they were taken and they were 141 and 172 on 12/20. And so these higher numbers can actually result from like metabolic stress, hydration, or overfeeding from like a tube feed. We also looked at his osmolality, and those normal levels are from 275 to 295. And on 12/15 when he came in, they were at 285, which was fine, but then they kept rising to 296 and then 299. And so those above normal values can suggest a patient is dehydrated. So he was still dehydrated while here in the hospital. We looked at the albumin, and it was at 3.2 when he came in on 12/15, and they continued to rise to 3.3 and 3.4. And though it is albumin, we still look at it because it can be a presentation of inflammation. And so we looked at those numbers, and MP is a mild deficient. And then for prealbumin, the normal levels are 18 to 35, and he was low on those when he came in at 16, and it dropped to 15 on 12/19, and then on 12/20 it rose back up to 17, but he's still under those normal values, which can be a preferred marker for protein malnutrition, and MP is also a mild deficient for that. We checked his C-reactive protein, which is supposed to be lower than 1.0, and he came in with 22 at 22. And then it rose on 12/19 35, and then dropped again on 12/20 to 15, and this is a big sign for inflammation in the body. We also looked at his white blood counts, which were 11.1 when he came in, which is high. and then they continue to rise to 11.9 and 12.4, and this can indicate, of course, a white blood cell increase, and which is to fight infection. Then we looked at his iron levels, because that's a big deal for Crohn's disease, and they were 62 when he came in, and these were not measured again. So they were 62 and 1215, which is lower than the 75 to 175 range, and this low lab result can be related to malnutrition, and then it can also be an indication that the small intestine is not absorbing nutrients as it should be. We looked at his ferritin, which was 17 when he came in, and that normal value should be 20 to 300. So that inflammation can affect the low lab result. His vitamin D levels were 22.7, which is lower than the 30 to 100 normal lab value, and this can be related to malnutrition. His hemoglobin was 12.9, and the normal values are 14 to 17. And those are connected to low iron or indication of iron deficiency anemia. And also the hematocrit was low as well at 38, when those normal values should be 41 to 51. And those can also lead to be an indication of iron deficiency anemia. And then the mean cell hemoglobin was at 26 when he came in, which is also an indication of iron deficiency, because those numbers should be 28 to 32. So his anthropometrics for our nutrition assessment. So he weighed 140 pounds when he came into the hospital, but he typically weighs 166 pounds. He is 69 inches tall. So we calculated his BMI to be 20.7, which is actually in the normal range. His weight change was about 25 pounds over 6 months. So we calculated his percent usual body weight to be 84.3%, which is in the category of moderate malnutrition, and his percent weight loss was 15.66%, which is severe over 6 months. So the biochemical data. So we looked at the osmolality, albumin, and prealbumin. So increased osmolality can suggest the patient is dehydrated, which can be an indication of diarrhea in the patient, which he does have. Albumin and prealbumin has increased from admittance. So, however, the labs are still below the desired values, which can be an indication that inflammation is still present and there is protein malnutrition. This is most likely due to MP's complication of the malabsorption in the inflamed areas of the small intestine. His C-reactive protein has been improved from the 22 to 15, which is an indication that inflammation is improving, but it's still there. His white blood cell counts, they are valued above the normal range, which is still an indication that there's an infection in the body. His iron, ferritin, and vitamin D values, they are below normal, and it's an indication that inflammation is still present in the small intestine and poor absorption is still occurring. Hemoglobin, hematocrit, and mean cell hemoglobin, they're still lower than the normal values, and it's an indication of iron deficiency anemia, which is due to poor iron absorption, which can also lead to iron deficiency anemia. Okay, so the clinical data. So the signs and symptoms MP showed are as listed. So he had a distended abdomen, extreme tenderness with rebound and guarding. His stool consistency was soft to liquid. He described that he had unbearable abdominal pain and diarrhea. He came in with a fever of 101.5 degrees Fahrenheit. And MP lost weight after the initial hospitalization of 25 pounds, then regained the same amount after his first hospitalization. The patient followed nutrition advice given to follow a low-fiber diet, and the patient drank boosts in between meals to regain the lost weight. However, recently, over the past 6 months, MP has unintentionally lost the 25 pounds once more. So his diet for the nutrition assessment, he provided us with a recent dietary intake. So he had, like I said before, he had been taking the boost in between meals and consuming a low-fiber diet for several months. However, this showed us that he was consuming low amounts of fruits and vegetables, and he was consuming chips, carbonated beverages, and he does not drink water, as indicated by our recent dietary intake. So MP has been unable to eat properly and has poor appetite due to the intense abdominal pain and the diarrhea. And MP has had previous nutrition counseling from when he was first diagnosed with the Crohn's disease. So he is currently taking the medication 6-mercaptopurine. Sorry, guys. There is no significant nutritional reaction while taking 6-mercaptopurine. In some, there may be a depletion of some vitamin absorption, such as calcium, taurine, phosphate, and sodium. MP is currently on a clear liquid diet, which is appropriate for managing his Crohn's disease because it helps the digestive system recover and can help maintain adequate hydration and provide important electrolytes. It also helps with the issue of inflammation in the small intestine and his diarrhea. So for his nutritional needs, so from MP's recent dietary intake, his current caloric intake is about 1,800 calories, and 60 grams of that is protein. We calculated his caloric needs using the Harris-Benedict equation, and his energy needs ranged from 2,500 to 2,800 kcal. So his EER was about 1574, and then we included a 1.2 sedentary or activity factor, 500 for weight gain because he lost so much weight, and then a fever, so say fever, my bad, fever factor of 331 because it's 7% of EER for every 1 degree above normal. So then when we calculated the EN, we used MP's admitted weight of 140 due to the struggles of maintaining their usual body weight. They had met 69% of their kcal requirement. MP was consuming about 60 grams of protein based on his recent dietary intake, which meant that they were not meeting their 95 grams of protein requirement, and they met about 63% of their protein requirements. So the protein requirement we calculated by using 1.5 grams per kilogram, and that was due to the Aspen guidelines suggesting 1.2 to 2.0 grams per kilogram for adults in intensive care. So we calculated that to be about 95 to 105 grams. We calculated his fluid needs by using the measurement 1 milliliter per kcal. So his EFN was calculated to be 2,500 to 2,800 milliliters. So due to the issues with malabsorption, as indicated by the labs, MP will need to increase their intake of vitamin D, iron, and vitamin A.
So his nutritional problem we determined was just malnutrition because of his previous diet is just not enough fiber, proteins, fruit. He's lost so much weight, and because of his constant diarrhea. Nutritional diagnosis is involuntary weight loss related to a decreased ability to consume sufficient energy due to Crohn's disease, as evidenced by weight loss of approximately 15% of weight in 6 months. Client's history of Crohn's and his loss of appetite due to severe diarrhea and abdominal pain is expressed in his 24-hour recall. The exact etiology of Crohn's, again, is not known, but there's evidence to suggest the disease is resulting from an inappropriate immune response in the bowel to situations from environment factors such as drugs, toxins, infections, or intestinal microbes. This chromosomal mutation in NOD2, or the CARD15, was found to be in association with Crohn's for kids at a younger age, but still there's not really any direct cause that we know of yet. And then signs and symptoms include considerable weight loss, unbearable abdominal pain, constant diarrhea, fever, reduced calorie count because of lack of appetite, and then a tender abdomen.
So for our nutrition intervention, we decided on that we need to increase the patient's nutrients and raise his overall caloric consumption. So while the patient is still in the hospital, we focused on eternal feeding, and due to its process of improving the patient's nutritional status because MP has been having difficulty eating due to abdominal pain and diarrhea. When MP goes home, we want him to eat small, frequent meals, consuming an increased level of fruits and vegetables, increased vitamin D supplementation, increased protein, and decreases caffeinated and carbonated beverages. We prioritize these interventions because we know that MP needs to consume more calories and increase his amount of micronutrients to help in the possibility of increased absorption. There's also a focus on lessening the amount of caffeinated and carbonated drinks due to an increased risk of inflammation flare-ups. So expected outcomes. We expect there to be some type of weight gain with the increased caloric consumption, decreased C-reactive protein because MP will have lower inflammation and infection in the small intestine, reduced abdominal pain and diarrhea due to decreased inflammation and increased ability for nutrient absorption to occur. Also increased vitamin D, iron, and vitamin A due to an increase of fruits, vegetables, protein, and supplementation where needed, and then also a decrease of inflammation. So our strategies. So the use of EN has also been shown to improve clinical markers of inflammation, such as C-reactive protein, which is high for MP and needs to be lowered. Initial strategy is just life changes, which includes changing MP's diet and nutrition education. The strategy of eating small, frequent meals is best for tolerating the issue initially. And then oral supplementation additionally is needed to decrease absorption in the small intestine. MP's initial workup indicated acute disease within the last 5 to 7 centimeters of the jejunum and the first 5 centimeters of the ileum. So our educational tools that we could use, we have like some tip sheets that we could hand out about Crohn's disease, about anything that would be irritable for their system, anything to look out for. We can also do like handouts on like the low fiber diet and Crohn's disease itself. And we can also present a sample meal plan as shown in the picture on the left. So our follow-up, we will follow up with MP in 2 weeks for essential labs such as C-reactive protein, ferritin, and iron. At this time, the intervention methods and strategies used will be evaluated. So this includes determining if labs have improved, how the food journal is working, evaluating the list of foods MP has cataloged that causes issues, and if MP shows a decrease in abdominal pain and a decrease in diarrhea. So if these have improved, we will meet with MP again in 2 weeks. Then once we keep seeing improvement, we'll see them once a month for 6 months and then once every 3 months. For monitoring and evaluation, so MP will keep a food journal for 2 times during the week and 1 time on the weekend at minimum to help us monitor their outcomes. He is also able to consume regular, small, frequent meals at the correct caloric intake of 2,500 to 2,800 kcal, along with an increased amount of protein to 25 to 105 grams. MP has hopefully increased their fruit and vegetable intake, included a vitamin D supplementation, and has shown a decrease in abdominal pain and diarrhea. We will also track MP's weight upon each visit. So some factors that could hinder MP meeting his goals are consuming foods and or drinks that may cause a flare-up. Therefore, in the food journal, MP will make notes when an issue arises with specific foods and or drinks to help improve upon meals he can consume regularly without the issues. Factors that can facilitate MP meeting his goals can include consuming smaller, more frequent meals consisting of lactose-free dairy and low-fiber foods, and also increasing his water intake. And these are our references.
Thanks, guys.